Hey guys, it's Rick Bigger. I'm going to go over the stroke training that we got from Kevin All at St. Francis. I'm going to recap it all and put it into, break it down into what he brought up and what applies to us directly. Okay, so starting with the main key points the main thing with strokes is to detect that early. We use the Cincinnati stroke scale here at Owasso, as he said over and over again. Stick to your protocols and stick to what we're already doing. Okay, so Cincinnati stroke scale, facial droop, arm drift, and slurred speech. That's the main things we're looking for to detect stroke. If they have one of these three that are going on, you got a 80% chance that that's a stroke. Next is call early, something you hit on quite a bit. It's important to call a stroke alert as soon as possible. We can even call those from on scene. Generally what I do is once we start the transport, I call the stroke alert. That gives about 15 to 20 minutes transport time for us, which is time for them to get ready. And he said you can call back with a report later. So kind of the procedure for that, you hop in the truck, as soon as you take off, call the hospital you're going to, let them know that you're calling a stroke alert for a 70-year-old male, and I'm gonna call back with a full report in about 5 to 10 minutes. And then you start going through all your stuff, doing your treatments, getting your IVs and all that en route, and then you can call a full report once you have everything. Okay, so breaking that stuff down through the training of what he hit on, that is important for us, you know, what we should be doing. First and foremost, through the stroke scale. Apologize, I wrote that in the wrong place. Do the stroke scale, and we use the Cincinnati and get detect that stroke. Once we figured out it's a stroke, okay, the next kind of question we have there, we think they're having a stroke. We need to figure out when's the last time that they were normal and get a phone number from family. Generally, that's the second person that's on scene can get that information while you're still assessing the patient. The third thing I need to do is knock out what our mimickers are. Okay, we think they have the signs of a stroke. We think it's going on. Let's make sure that we don't have a mimicker and it's actually a stroke. The first thing is history of seizures. Second is checking their blood sugar. And third is checking a temperature. Okay, obviously you can use these depending on the situation. A person that was 36 years old is not going to be affected like a fever like somebody that's 96-year-old in the nursing home. Some of these may be able to wait till later, but these are questions quickly that you can ask. Do they have a history of seizures? Are they a diabetic? Or ever have problems with their blood sugar? And have they been sick, etc., especially if they're older? Okay, so bam, we've knocked those three out. I assess them for the stroke. I get rid of the mimickers, and my partner's figuring out when the last time they were normal is and getting a phone number, contact phone number of somebody in the family. Okay, once I have that, I can get them in the truck, and we're gonna get them out of there. So how do we determine if we call a stroke alert? If the last seen normal time is less than 6 hours. So it's been 6 hours or less to what they believe the last seen normal time is. We're gonna call a stroke alert, and we're gonna immediately transport them. Right, if it's over 6 hours, we don't have to call a stroke alert because TPA, the TPA window is gone. We can only use it for about 4.5 hours. So that's what that is using. And it puts some leeway in there. So as Kevin talked about, these last seen normal times sometimes vary. And you're not always getting good information, so they give some leeway. Right, so stroke alert, the last seen normal is less than 6 hours, and immediately transport them. What do we do en route? Okay, things for us. Vital signs. Get a set of vitals. One of the things we can do with this set of vitals is they should have a high blood pressure. They probably have a high blood pressure, and that's another sign that it is a stroke. Right? We're looking for get IVs ×2. They need to be 20 or bigger. Anything smaller than a 20 is not going to work, so you might as well wait. We need a 20 or bigger IV. We need at least one, preferably two, and at least one of those needs to be in the AC, preferably both. So starting 2 20 or larger IVs in the AC is what they're looking for. Do not start an IO unless you need it for some cardiac arrest reason, but do not start an IO. They cannot use that. Do not start an EJ unless you need it immediately, because they will not be able to use that either. Okay, if you put clot busting drug through there, right, he's talked about how it'll blow up. You won't be able to see what's going on, see what they need to do. Okay. Last is allow the blood pressure to be high. We don't have labetalol or anything else to treat, so some people here use nitro to treat blood pressure. Do not ever use that in a stroke. So never use nitro. We never want to try to use nitro to bring their blood pressure down in a stroke. ever. That's definitive. Not maybe, but never. Okay. Last is good neuro assessments, and we'll move on to some of these, such as the pupils. This is where we're going to find this at. So they're having a stroke. We've got all their vitals. We've got their IVs. Everything's in gear. We need to see what their GCS is initially, what their pupils look like initially, and how these things change throughout the transport. Okay, so you have an assessment in the beginning, an assessment in the end for us, because we only have about 15 minutes of transport time. So we have one in the beginning, one in the end. If it's a longer transport than that, for some reason, there should be one in the middle as well. Okay, we need to be checking that person and see if they're declining. And if they are, we need to let the hospital know that and document that. The very end there, how's the hospital grade us on whether or not we did a good job on the stroke? And they gave us these 11 things that we can look through. Okay, and it's covered all by what we just talked about. Right? Did we get a lasting normal time? Did we tell them what that is, and did we document that? Okay, that should be documented in your narrative. Did we supply them with a GCS? Let them know what the GCS was. Was that in the assessment? Was it documented in the narrative? Did we check a blood sugar to eliminate a mimicker? Okay, if we did, is it documented? Verbal and written. Did we check their pupils during assessment? Did we find something? That's one of the most definitive. It's right close to the brain, so it's very definitive in a stroke. One being larger than the other, or both pinpoint, or both blown, lets us know some stuff. Did we check that? And did we tell them and document it in the narrative? Did we do a stroke scale? Same thing. Did we tell them the results and document the narrative? Good sets of vital signs. Did we list the medications or interventions that we did? If we did give medications, we don't give a lot of medications in strokes, but if we did we document it? And then was there decline en route? Okay, and how they figure that out is multiple GCSs. Did we do multiple neuro assessments throughout and document the GCS changes? Was there a phone number in the narrative? Okay, family contact phone number. So all the information that we give them, once they go to start giving that clot busting drug, they're going to recall that family. They're going to start asking questions, getting more. They're going to basically do everything we did again to verify everything and make sure that they're on the right track, because as we know, we get a lot of conflicting information. So, and that phone number needs to be written in the narrative. That's where that S section in your charts comes into play. Medication list. Did we get a med list from them? A lot of times, as he said, a lot of times these are already in their system, but we need to try to get as many as we can. If they have a list, grab it. Same with past medical history. That's where they're going to find things such as AFib, which could be important. Do they take blood thinners, which could be important? Do they have a history of seizures? Are they a diabetic? Have they had a stroke in the past? Etc. What is their normal before this started? They figure that out through past medical history. So that takes his training and everything they went through, wraps it into a nutshell, does it real quick. So just some tips on strokes. We had this training not that long ago, and ours was almost identical to this. So we're doing a good job on our stuff. This is just taking what he gave us and wrapping it up, and hopefully you guys pick some stuff up out of this. Thanks for watching, guys. Make sure that if you do watch this, make sure to fill out 1085 so that you get credit for it and get it to your shift rep. Thank you.